All right, we've reached 9 o'clock. I think we might as well get started. Good morning, everyone. Welcome to the McMaster Regional Clinical Rounds for the Division of Respiorlogy. For those of you who don't know me, I'm Marcel Tunks. I've been the clinical lead for our pulmonary function lab for a number of years. Today I'm going to be talking about the recent statements and standards submitted by members of the ATS and ERS. There's been some particular interest in the latest technical standards for interpretative strategies for pulmonary function tests that were released this year, and that was sort of the stimulus for the discussion today. So I'll provide a bit of an introduction to some of the recent statements that have come out, and then leave lots of time for discussion. So I don't have any financial disclosures. I don't have any affiliation with any of the companies that make any of these products. We'll talk about some of the recent reporting recommendations, discuss some of the conflicts and controversies, try to propose a path forward, but what I'm most interested in is starting a discussion in the respirology community, both at McMaster and across the province. So one of the basic principles to remind ourselves about is that taller people have bigger lungs. And the relationship is roughly related to the height squared. If you take people of a given gender, of a given ethnic group in a given geographic location, there is a very close relationship between the volume of somebody's lungs and their height to the power of roughly 2. Men have bigger lungs than women on average. So if you take a man and a woman of equal height and equal age, the man is likely to have larger lungs than the woman. So that has an influence on lung volume if using height, age, and sex as a prediction. Now that's sex, not gender. And then there's age. So obviously your lungs get bigger as you mature until you reach around age 25, and then it's all downhill from there. So as you're maturing from childhood to age 25, most of that's related to increases in height, but the decline in later age, even if the height stays the same, the lung volumes do decline a bit with age, so age does play a role. Now, FEV1 over VC, airflow also declines with age. The lungs lose their elastance. Just like the skin loses its elastance and becomes wrinkly, the lungs lose their elastance and become wrinkly, and airflow goes down. So FEV1 over VC declines with age. So why am I talking about these variables? The reason is if the lung function varies with these things, then there's going to be bias. With respect to age, the variability also goes up in the elderly, and then the variability is also higher in very young people. And some of that's going to be related to technique. If you've ever actually made somebody do spirometry, little kids have a hard time. People in their 90s might have a hard time. So some of it's technique, and some of it is just increasing variability with varying disease states and that sort of thing. And this variability is fairly consistent amongst the various reference equations that are out there. So this isn't a thing that's unique to GLI. It's just something that wasn't emphasized until the 2005 guidelines. So because of all this, because of the increasing variation in lung volume with age, the natural decline in vital capacity and the natural decline in airflow with age, if you use a fixed cutoff of 80% for FEV1, or fixed cutoff of 0.7 for the FEV1 to FVC ratio, you're going to overcall disease in the elderly. So by age 80, 70 to 80% of people in a presumably healthy population are going to be classified as abnormal. And this may not be acceptable. So partly in response to this, the 2005 ATS-ERS statement for interpretative strategies for lung function tests advocated that we move towards 5th percentile values instead of the 80 to 120% for the various lung volumes, or the fixed cutoff of 70% for FEV1 over FVC. So the previous practice might have used the FEV1 over FVC ratio less than 0.7 as defining obstruction, and that would be chosen from the single maneuver that provided the largest sum of FEV1 and FVC. The new approach was to use FEV1 over VC below the 5th percentile. Now that was FEV1 over the biggest measured reliable VC, whether it was forced or slow, and we'll talk about why they did that and why it might be changing. They also recommended that mid-expiratory flows not be reported. The mid-expiratory flows get used still by some people to maybe improve sensitivity for airflow obstruction or for people who can't do vital capacity maneuvers. But really what you're doing is trying to apply a number to the qualitative appearance of the flow volume curve. So the 2005 statement, because of the lack of reliability of these numbers, suggested that we stop reporting mid-expiratory flows. So that was 2005. That's some time ago. Obviously, not everyone has caught up with that, and not everyone has moved forward with this. For example, various COPD guidelines, many of them still stick with the fixed cutoff of 70% as defining obstruction. So lung function does go down with age. The lung size goes down, and airflow goes down with age. And we don't want to overcall disease. This might just be normal aging. The problem is it's hard to decide what's normal and what's abnormal. And if you're trying to characterize a population, there's a limit to how much you can do when you're taking thousands of patients to derive a set of reference equations. How far can you dig in a multi-center study, a global study, to decide that these people are normal or typical or healthy? And even if it is typical aging, is it healthy aging, or are there actual signs of disease? The example that I think illustrates this is how opinions have changed about hypertension with age. So blood pressure naturally goes up with age, and but there seems to be no impact on mortality of the increase in blood pressure with age. And treating hypertension in the elderly did not influence mortality. So for a long time, guidelines suggested different cutoffs for hypertension treatment in the elderly compared to younger people. However, there are important outcomes other than death for an individual. For hypertension, that might include things like myocardial infarction, stroke, or cognitive decline. And it's been found that treating hypertension in the elderly, even frail elderly, can reduce the risk of those cardiovascular outcomes or of cognitive decline. So there's increasing interest in treating hypertension, which was previously considered normal aging. Now, it's possible that we're just a decade behind the cardiologists in figuring out if the decline in lung function with age is truly normal aging, or if it's a sign of diseases that people accumulate over time. With respect to lung function, there are potentially several things that might contribute to the decline that might be real and might be important. One would be osteoporosis. So there's some evidence that as the number of osteoporotic compression fractures accumulate, that lung function goes down. People lose height, but they lose height preferentially in their thorax, and abdomen. So that has the potential to cause a decline in vital capacity and FEV1. And for patients with COPD, who have fresh vertebral compression fractures, vital capacity and FEV1 improve if you do vertebroplasty. So osteoporosis is a condition that accumulates with age and is potentially avoidable, or can at least be minimized with interventions. Another would be sarcopenia, which is common with age, and it's typical of aging for muscle loss. You can see the illustration in the middle, MRI of quadriceps muscles. There's an athlete at the top, a sedentary adult in the middle, and then a 70-year-old triathlete at the bottom. And you can see that sarcopenia might be avoidable in some individuals with the appropriate nutritional, environmental, and possibly hormonal interventions. And muscle strength matters when it comes to lung function. So there was a study that was done in London, Ontario, where they took subjects from a property tax database aged 55 to 86. So this is older individuals who with no previously diagnosed lung disease and a self-reported walk history of a minimum of 80 meters as a screen. Then they brought them in, did a history, medical exam, and ECG to screen for any underlying comorbid conditions. They found that the subjects with higher fat-free mass, higher grip strength, so more muscle, had better lung function. This shouldn't be too surprising. But you know, the loss of muscle with age might be avoidable in some people, and the people who don't lose that muscle, people preserve muscle function, have better lung function. So there might be some information lost that might be relevant to people's symptoms if we just use a 5th percentile value based on a reference population that's incompletely characterized. So that's a bit of the background. In 2019, there was an update to spirometry standards it was mostly similar to what has been done previously, but they added quality grading. They started with what's an acceptable test, which is very similar to what was there before. So no hesitation, free from artifacts, no coughing. They don't abruptly terminate on the expiratory part of the maneuver. There's maximal effort provided, which is more of a qualitative term, and the mouthpiece is not obstructed, which requires some expertise on the part of the tech. And if the maneuvers are acceptable, we move on to the quality grading. Previously, you needed to do a minimum of 3 maneuvers, and 2 of them had to be close to one another. They had to be reproducible, with slightly different cutoffs for adults and children. Now they have quality grading A, B, C, D, E, F, and U. The previous guidelines would give you a quality grade of a B. Quality grade of A would be if there were 3 acceptable maneuvers that are closely repeatable. So then you have a higher confidence that the numbers you are seeing are real. If you were only able to reproduce it twice, then you have a little bit less confidence, but it's still pretty good. If the variability starts to go up, it's a C. If it goes up more, it's a D. If you only get 1 acceptable test, it's an E. If there are no acceptable tests, it's an F, and the numbers become very hard to interpret. U is interesting because that's one where it's usable but not acceptable. So when would that be? That would be if, for example, there's somebody who, no matter what you do, you can't get a reliable vital capacity, but their FEV1 is very reliable. That might be useful for pre and post bronchodilator testing. And this is something that might come up, especially in kids, where they're not, even an FEV6 might be hard for them to do. So you might have usable maneuvers, even though they're not acceptable, but they're useful for answering a specific question. They did make some additional changes in those spirometry standards. They recommended GLI, which makes sense since some of the authors were the people who are involved in GLI, and also because it's the biggest data set there is, especially in younger people. 74,000 subjects, 57,000 of them Caucasian, half of them under the age of 20. So it's the biggest pediatric data set by far. It's the biggest adult data set for a global number. So they recommended GLI be used as the standard. They also added a couple of things, that more routine use of the FEV 0.75 for children under the age of 7. So 6 and under, they recommend using the FEV 0.75 and the FEV 0.75 over FVC or over FEV6. All of which are available in the GLI data sets, but not all of which are available in your PFT software you might be using in your lab. So this is the recommendation because small people have smaller lungs and there's not less air moves, and they might blow out their entire forced expiratory volume in under a second. So you can't use FEV1. So there's FEV 0.75. And they recommend that if that child can breathe out for longer than a second, that you can report FEV1 as well. So that's something new. There are some additional comments about training of the techs, about safety parameters for the lab, and about patient activities to be avoided before the test. Some of this would be similar to what's in the CPSO IHF guidelines, and some of it would be some other additions. And then the last was something that's somewhat confusing. End of expiration, basically it needs to be a minimum of 6 seconds, preferably as close to 15 seconds as possible of expiratory effort, with cessation, gradual cessation of flow, so gradually tapering to less than 25 mils per second. Ideally, it would be repeatable. So that's end of forced expiration. If they meet those criteria, you get that check mark and you have the potential to have an acceptable maneuver. If you don't meet one of these criteria in this flow chart here, then it's not considered an acceptable maneuver. It might be usable in terms of FEV1, but it might not be acceptable in terms of a quality grade. So A, B, C, D, E, F, or U. It would be an F. The DLCO guidelines were also updated. And similarly, they provided a quality score of A, B, C, D, or F. They don't provide a U. And once again, the old guidelines at best would give you a B, a score of a B. Maybe an A if it was a very reproducible FEV1. So when you do a DLCO maneuver, they exhale all the way, they inhale all the way with a known concentration of carbon monoxide, a known concentration of a non-absorbed gas to measure your alveolar volume. So your thoracic gas volume by gas dilution over that 10-second period. 85% of people can get to 85% of their best VC during a DLCO maneuver. So 85% of people can get a B. Maybe an A if it's very reproducible. So for an A, you want to get to 90% of your best VC. Or it could be 85% if your VA is very reproducible, so within 200 mils. So A or B, I think A is pushing it. I think B is more realistic. Because at least 15% of people can't get an A or a B. So that's a lot of people where the maneuvers would no longer be considered acceptable. So what do you do if they're not acceptable? If you have grade A and repeatable numbers, they say report it. Report the best one or report the average one. If you have grade A efforts, but they're not repeatable, they're not close enough to one another, they're not within 2 mils per minute per millimeter of mercury, but they're grade A anyway, then you average the 2 grade A efforts and report it with comments. If you get 1 grade A effort and the others are lower, you report only that 1 grade A effort with comments. If it's grade B to D, you average the efforts and report them with comments, which is similar to what we did in the past. And if it's grade F, you don't report it at all. So if they get to less than 80% of their best VC maneuver, and the sample collection is greater than 5 seconds, and they hold their breath for less than 8 or greater than 12 seconds, is not considered acceptable, and it shouldn't be reported at all. Anemia, they reinforced the old formulas, which are largely derived from undergrad kinesiology students who were repeatedly phlebotomized and had their DLCO done over and over again. Now, those people can increase their cardiac output in response to anemia and volume depletion. So the change in your DLCO based on a drop of hemoglobin, for every 10-point drop in your hemoglobin, the DLCO only goes down by around 4% in that population. That might not be the case for somebody who can't increase their cardiac output as much. So there's some newer reference equations out there that suggest that the decline in DLCO might be closer to 1-to-1 in some populations, but the data is sparse, and they still advocate using the old formulas. So it's a bit of a problem, and then they say that we should adjust for anemia in everybody. And this will underestimate the impact of anemia in older and sicker patients. It's not always easy to find that hemoglobin and do that adjustment. The standard is to adjust the predicted value. You're not supposed to adjust your percent predicted. You're not supposed to adjust the measured value. You're supposed to change the predicted value based on their hemoglobin. But that rough estimate of a 4% drop for every 10 grams per liter drop in hemoglobin, it's approximately right. It's somewhat reasonable. And given the uncertainty about how much anemia affects DLCO, I'm not sure how picky one would need to be. Now, with these new standards for how the maneuvers are to be performed, there are some newer standards on how pulmonary function tests are supposed to be reported that reflect some of these changes in philosophy, moving more towards more statistically sound ways of looking at things. Instead of using fixed volumes, like a 200 ml decline in FEV1, which would be biased against the older people, would be biased against younger people, it would be biased against women. It would be biased based on gender, to start to move towards percentile values and Z scores. In order to put that into practice, it needs to be in the report. So how might that look? The ATS provided an example of how a report might look. And they recommend that smoking status be on a spirometry report, which some places do and some places don't. I find it tremendously valuable because pre-test probability should be included if possible in your interpretation when you're trying to understand what's wrong with the patient. The reference value has been omitted. So instead of having the predicted value for vital capacity and their measured value and the upper and lower limits of normal and the Z-score and the percent predicted, they just omit the predicted value because it doesn't really add anything when you're looking at, because you get the percent predicted anyway, you get the Z-score and you know the upper, the lower limit of normal. So they recommend that the tabular data include all of those things, and that the post-bronchodilator include the volume change and the percent change. And now they had percent change from baseline here, which is what we've done forever, which is potentially changing in the future. Now for the Z-score number is, I think, requires a bit more thought. When you look at it, you have to do a bit of math in your head, figure out where people land. So I like the fact that they advocate for this graphical representation of the Z-score, where you have this color-coded green area where you're within the expected range for your population, and you have this increasing degree of certainty that this person is below the expected range as the Z-score declines. And they reinforce that you shouldn't draw a line in the sand. If somebody's in the 6th percentile compared to the 4th percentile, that's not a real difference. So somebody might be at the lower limit of normal, and pulmonary function tests would ideally be described in that way rather than having an automated flowchart kind of interpretation. But that obviously requires some expertise. So this is what's recommended, that you have this graphical representation of Z scores. Test quality scores are supposed to be right on the report: A, B, C, D, F. You lose some data there by having just a quality score without knowing which part of it they failed. Which part of it they failed will influence the report. And that's where the volume time curve comes in. So they advocate putting it right in the report. At a minimum, it should be in front of you when you're doing your interpretation. It would be nice to have it in the report, but it may not be practical because this is just spirometry and it fills up an entire page. So if the quality grade is an A or a B, then you can just go ahead and interpret the thing. If the quality grade is a C or a D, then just having the quality grade loses some data. What part of it did they not do correctly? And this is where the volume time curve and the shape of the flow volume curve are helpful. So if the person hesitated, all right, I think I lost my audio there for a minute. if the person hesitated, then you're going to underestimate the FEV1. If they cut off their expiratory effort early, you're going to underestimate the vital capacity. Now, the latter is much more common. So if you just look at the flow volume curve, it's very easy to miss that this person stopped early. So if you are reporting spirometries and pulmonary function tests, and you just see a quality grade in terms of a number, and you only see the flow volume curve, you will miss that vital capacity is underestimated, and you will miss airflow obstruction if you're using an FEV1 to FVC. So having that volume time curve is very helpful in that situation. So if quality is C or D, then this becomes very important. Lung volumes, we are also intended to use Z-scores and upper and lower limits of normal. They advocate putting the pressure volume graph on there. It's helpful when interpreting a PFT. Having it in the report that goes out to a family doctor, I think, loses some information, and it makes the report a little more busy. I don't think it adds as much. I think it would probably make more sense if you're also doing resistance measures to have the pressure flow curve instead of the pressure volume curve, because then you get a sense of the shape. Is the resistance upper airway? Is it lower airway? Or just don't include those at all, because those can be very confusing for people. But that's what they advocate anyway. And they have result bars instead of instead of the horizontal graph that they had before. Now they have this vertical bar graph where they have the upper and lower limits of normal. I don't know that that's necessary to do it that way. I think it could have been flipped sideways. I'm not sure why they did it this way. They also include the inspiratory capacity ERV curve. Now, yes, this is how the maneuver is done, but I don't think that this provides useful information. I think if you want to look at how the maneuver was done, then you should look at the curve of their tidal efforts followed by their big breath in, their big breath out, and then their inspiratory effort. I think that makes more sense to look at in terms of quality rather than this bar graph in blue, red, and gray that you see there. I don't think that adds a lot of information. So my preference would be to not include it. DLCO, for some reason, they included only the lower limit of normal here, but they talk about how our upper limit of normal might be important in conditions like polycythemia, left to right shunt, obesity, potentially asthma. So really, the upper and lower limit of normal should be there, and they can either be separate columns, or it can be a range in brackets or something like that. But upper limit of normal should be on there. It wasn't in there in the guideline document, but it really should be there. Now again, that bar graph is horizontal again, like it was for spirometry. They have the concentration versus time curve on here, along with the collection point. So the collection point is the gray bar in the concentration versus time curve. Now, this is something that the techs do to decide where the tracer gas should be collected. Now there's an this is done automatically by the software, but an expert tech can move this bar around. This is especially important in people with airflow obstruction, but in anyone they can move this around. Now, plotting it against time, there's an example on the right here where you can see it's the same tracer gas pattern plotted against time on the left and plotted against volume on the right. A tech would look at this. The automated software provided measured the tracer gas on the top left, and they saw a plateau, and the software said, oh, do it here. A tech might look at that and say, it's a little too close to that inflection point. Let's move it over. So they moved it over, the tech moves it over to here. It's farther than it needs to be. So there's more of a delay than there needed to be. And that might be an overcorrection of where the tracer gas should have been collected. It could have been collected a little bit earlier. So if a tech is doing this adjustment, rather than using concentration versus time, it would be ideal for them to use concentration versus volume. On a report, however, I don't agree that it should be concentration versus volume as they talk about in the text. So they have this confusing thing where they plot it against time, but in the body text, they say it should actually be plotted against volume in your report. I disagree. I think plotting it against time makes more sense, but if you're going to plot it against time, if you're going to show the curve, show the whole curve. Show the whole inspiratory effort, the whole inspiratory volume, the entire breath hold time, so you know you have a visual representation of whether they held their breath for 10 seconds. Show the expiratory part of the maneuver, and some of the PFT equipment will also give you the airway pressure, and you'll know if they did a Mueller or Valsalva maneuver. So I find the graph of concentration versus time that has the volume on it and the airway pressure to be tremendously valuable when evaluating the quality of a DLCO maneuver. So if we're going to have something on there, why, and it's going to take up that space, why not include the whole graph? So I don't entirely agree with the standards there. So then we move on to the more recent documents and the thing people I think are most interested in, the ATS ERS technical standards on interpretative strategies for routine lung function tests. This was 2022. This is part of a large flurry of guidelines submitted by various organizations during the pandemic. And the focus for this particular document is on normal populations and lower limits of normal. The lead author is one of the people heavily involved in GLI, and a lot of the emphasis is with that slant to it. That we want to try to really understand what is within the normal limits and what is beyond the norms within a population, so that we try to avoid misclassifying healthy people as being abnormal. So obviously they recommend the GLI. They validating reference equations in your own lab with your own populations, even if you have 1,000 subjects, is no longer recommended, which is interesting. But that might depend on where you are geographically. If you're working with an Inuit population, for example, these reference equations are too low. Because limb length is shorter relative to height, probably maybe because of socioeconomic factors, maybe more than truly racial things. But they recommend not validating reference equations in your own lab because you might get Z scores that are too broad. Race-specific equations are recommended instead of adjusting the Caucasian data. So instead of taking whatever the Caucasian data is and multiplying it by 0.88 for African-American population, they recommend having race-specific equations because the whole curve may be different in different populations. So those are some of the key changes right off the bat. They also advocate a return to FEV1 over FVC. Now, from a purely stats perspective, this is the thing that is most correct. That what they have measured in these studies is FEV1 over FVC. They measure the FEV1, they measure the FVC. They don't do a slow VC in this population. So why would you use a slow VC when you're interpreting your pulmonary function test? I think that there are advantages and disadvantages to each of the three approaches. So the old way, which is still used in some situations, especially in the investigation of somebody for possible COPD, FEV1 over FVC less than 70% would be very sensitive for emphysema. It will overcall obstruction in the elderly. And a population of 80-year-olds, 80% of them will have airflow obstruction if you use this fixed cutoff. So you're going to overcall obstruction in the elderly. You'll miss it in young people. So it certainly has problems. There's a high rate of false positives. There's going to be false negatives in younger people. So it's really not great. The FEV1 over VC max less than the 5th percentile that was advocated in 2005 is sort of interesting. We'll come back to that in a moment. The newest guidelines return to FEV1 over FVC, and they want a number below the 5th percentile. This is going to have a very low sensitivity for a condition such as emphysema. it will miss cases of airway closure if you're using FVC. So some people have very collapsible airways with conditions like emphysema. And if you use your FEV1 over FVC, it might look normal. And the FEV1 compared to the largest VC may be very low, and the airways resistance may be very high. So you will miss cases of airway closure. And if all you have is spirometry, you might miss COPD. It is, again, it's more correct in terms of epidemiology. They recommend choosing the best FEV1 and the best FVC, and they don't necessarily have to be from the same maneuver, but it should be FEV1 and it should be FVC according to the new guidelines. VC could be used with caution if the FVCs are not acceptable. And again, an unacceptable FVC, somebody failing to reach that beyond 6 seconds in that plateau, is probably the most common, one of the most common problems with spirometry technique. So it'd be very common that your FVC is underestimated. So you can use the largest measured VC, but it's to be used with caution, and ideally would it be accompanied by a comment. The approach from 2005, where they used the FEV1 over VC max less than the 5th percentile, it's sort of a compromise between the two. And it better captures cases of airway closure than using FVC in either circumstance. But it's not what was done in the study, in the reference populations. They didn't use slow VC, they used FVC. So that's why it has changed again. Bronchodilator response has changed. And again, big people have big lungs, smaller people have small lungs. So using a fixed cutoff of 200 milliliters to define a significant change makes no sense. The 200 mil number also just makes no sense in general. If you look at the general population, the variability in FEV1, the 95th percentile value, is as low as 150 milliliters in some populations. So if you take well-trained subjects, especially younger people, the variability of FEV1 is going to be closer to 8% and closer to 150 milliliters. So this 12% and 200 mil number is of historical significance, and it's used in many guidelines. And we know what it means when somebody has that change, that it's unequivocally there is a difference as long as the person's not very tall. But it's problematic, and it's kind of, you know, a made-up compromise. So the newer standard used some data showing cutoffs of 8% or cutoffs of 10% in various populations for bronchodilator response are associated with differences in survival. So if you look at a large group of subjects, those with a bit of airflow obstruction, if they have a bronchodilator response greater than 10% of the predicted value, or greater than 8% of the predicted value, not of the baseline, but of the predicted value, that's associated with better survival. Using this approach of change relative to the predicted value will reduce bias with respect to height, age, and gender. So there are definitely some advantages there. One of the problems, though, is that if somebody has low lung function to begin with, a change of 10% of the predicted value might not be realistic. And somebody going from an FEV1 of 35% to an FEV1 of 40% would not be considered significant by these criteria, but might mean that this person is no longer hypercarbic, or that they can now make their bed. They can now shower independently. This data is derived from normal or very mildly diseased populations, not of people who have disease. So it will miss clinically important changes when FEV1 is low. This approach has also not been validated in children. So we have a guideline that says we should use this cutoff that has not been validated. Now, the 200 mil number was also not really well validated. It's sort of a reasonable number, a compromise. So the question from Dr. Hambley is, when looking at the greater than 10% of predicted FEV1, is this a relative or absolute change in percent predicted? This is an absolute change of 10% in the FEV1 of 10% of the predicted value. So if your predicted value was 4 liters, then a change of 400 milliliters in the FEV1 would be considered significant. So it's a compromise, and it makes sense for large populations of healthy people, but it might not make sense for people who have significant disease. And I think we're gonna aim for questions at the end. I see someone's hand is raised. Feel free to type questions in the Q&A, or for the when we get to the end, Victoria will hopefully be able to unmute you for questions. Change over time is something that was very confusing. So change over time, using a volume or relative change from baseline that was used in the older guidelines, 200 mil change in your FEV1, for example, or 200 mil change in the vital capacity, which also made no sense, are biased with respect to height, age, and sex. And those numbers, again, are cutoffs that are largely by consensus and not necessarily supported by the data. So we have these somewhat arbitrary numbers that have been abandoned for also potentially slightly arbitrary numbers. But these newer, more arbitrary measures are supported by maybe a bit more evidence. So one of these is FEV1Q. And I know that there was a lot of confusion about FEV1Q. There was a study that took a reference population of a few thousand people. They found the first percentile value for men and the first percentile value for women for FEV1. And they found that the number for first percentile value for FEV1 in men was 0.5 liters. And if you take the person's FEV1 and divide it by this first percentile value number, and then you look at somebody who's 10 years older and take their FEV1 and divide it by that 0.5 value, you find that it doesn't change very much. So rather than using a 30 mil per year decline in FEV1 as being the expected norm and greater than 80 or 160 mils being maybe significant, which would be biased based on height, age, and sex, they recommend using something that is not biased based on height, age, and sex. And there doesn't appear to be much of a bias here. Even though they're using fixed values of the first percentile for the population, not the first percentile for somebody of that height and age. So it's a little bit confusing, but this is a number that doesn't change very much over time. So for the general population, there's a good correlation in decline in this number with mortality and with COPD exacerbation in terms of quartiles. So if you divide the FEV1Q into quartiles, you see that the people with a lower FEV1Q have more bad things happen to them. They're more likely to die. They're more likely to have COPD exacerbations. This is a very small number of studies, though. The minimum clinically important difference has not been defined. And it's very strange that they're using these fixed cutoffs of 0.5 for men and 0.4 for women, because now you're biased against height, age, and sex again. So perhaps it should be modified to use the fifth percentile for somebody of that size, age, and sex instead of these fixed numbers. The original paper claiming superiority of this approach compared this sex-specific FEV1Q to an FEV1 over the height squared or the height cubed, but the FEV1 over height was not taking sex into account. So rather than have a height-specific FEV1 to height squared, they used the whole population, and then they said that the correlation between FEV1Q and survival was very slightly better than FEV1 over height squared. It wasn't a lot better. It was only slightly better. So I think more work needs to be done on FEV1Q. There have been other ways of looking at change in lung function over time in various studies. So in interstitial lung disease, there have been a number of papers more recently that rather than a 10% relative change in vital capacity over time, they used a 10% of the predicted vital capacity as a significant change. So again, if you have somebody who for their height and age should have a vital capacity of 4 liters, then a 400 mil decline in vital capacity over the course of the study would be considered significant. So, and that's similar to what they did with bronchodilator change. So why didn't they examine this or propose this as a possible option in looking at changes over time for vital capacity or FEV1? And then also, why not FEV1 over the height squared, which is I think a reasonably well-established way of looking at lung function that's less biased with respect to height and age, and it could be sex specific. So it's a little strange that we have this very small number of studies and they advocate for making this change to FEV1Q. I think more work needs to be done before the change is made. In children, they advocate a different approach, the conditional change score, which sounds baffling, but essentially what you're looking at is a significant change in the Z score. And you don't subtract the Z scores. You don't take their Z score before was a -1, and now it's a -3, and therefore it's a change of 2, and therefore significant. You actually have to do some math to figure out if it's a significant change in Z score, because there's an expected range in the Z score. The Z scores themselves have a degree of confidence associated with them. And a significant change is supposed to be a couple of standard deviations away from where the Z score was before. This is commonly used for growth and development in children. So if you have a child whose growth is starting to fall off of the growth chart, is their change from this percentile to that percentile significant or not? You don't add and subtract percentiles. You don't add and subtract the Z scores. You have to see, is the change in the Z score significant? So use a conditional change score. So this is actually very well established for growth and development in children. It has not been validated in pulmonary function testing. There was a study in kids, a lot more work needs to be done in this. It's not that it's a bad approach. In fact, it sounds like a very good approach. It makes a lot of sense. It might even be applicable in adults. It just needs to be validated. So again, we have previous recommendations that were not validated, and we have new recommendations that are also not validated, but might have a bit more rationale behind them. Speaking of Z scores, for severity, rather than grading severity based on percent predicted, they advocate basing severity based on Z score. I don't entirely agree with this. However, the severity criteria that we have, 35, 40, 50, 60, 70, is made up. It was arbitrary, with the exception of the 35%. The rest of them are arbitrary. So this equally arbitrary Z score range is maybe no better, maybe no worse, depending on what you're looking at. So how far do you deviate from the population norm is what's being advocated as grading severity rather than functional status. There are some advantages to using percent predicted for grading severity, so sticking to the old ways. Particularly with respect to FEV1. So FEV1 percent predicted gives you some useful information. For example, resting hypercarbia tends to develop when your FEV1 drops below 40% in somebody who's not obese and does not have obesity or OSA, especially when it drops below around 33 to 36%. So that old cutoff of very severe obstruction, that's the point where somebody without sleep disorder breathing would become hypercarbic. The old way of using a fixed cutoff of 1 liter is biased based on height, age, and sex and should not be used. But the old cutoff for very severe obstruction makes sense for resting hypercarbia. Similarly, with respect to exercise capacity, if your FEV1 is half the expected value, your breathing capacity at maximum exercise is going to be half the expected value, and a sedentary person will have ventilatory limitation at peak exercise. Most sedentary people have lots of ventilatory reserve. They get to 70 to no more than 85% of their maximum ventilation at peak exercise. So if somebody is dropping below 80%, their lungs are starting to limit them. That might be functionally significant, even if it's within the established population norms. So functional classification should be based on Z scores, or should be based on things like symptoms, activities of daily living, exercise capacity. CO2 clearance with exertion is a great example, where you can accurately, for moderate to severe COPD, you can very accurately predict their maximum ventilation at peak exercise by taking your FEV1 and multiplying by 37.5. Or it's actually more like 37, but that's a very accurate way of determining their maximum breathing capacity during exercise. So percent predicted, I think, makes sense when you're classifying people in terms of function. But the current guidelines are saying that we shouldn't do it anymore. Lung volumes, RV to TLC is back as an alternative to RV alone for patients to classify air trapping. So the recommendations, my suggestions would be for the reference values to use GLI where possible, where it makes sense to do so. Lower limits of normal and Z-scores are preferred, even though they're not perfect. Uncertainty should be acknowledged. Severity range, it's hard to know what to do with this. Spirometry and DLCO updates, quality scores are supposed to be on there. Include FEV 1.75 for children under 7 if possible. The PFT reports, if your software supports it, then having those graphs can be very useful. As for the technical standards for interpretative strategies, they've suggested that we abandon some arbitrary values and replace them with slightly less arbitrary values that haven't been fully validated. So I think that some of these recommendations are reasonable, but I don't think there's a hurry to implement them. I think that they require validation in populations with disease, not just patients who are presumably normal. So FEV1Q and conditional change scores need additional validation. The bronchodilator response of 10% needs validation. Should it be 8? Should it be 10? It needs validation in asthma and other airway diseases. In general, the new recommendations are probably the best choice for population health screening, survival prediction, occupational health. They might not be the best if you're investigating somebody for why they are feeling short of breath. All right, so we have some questions already. So Dr. Corvo says that at the McMaster Children's Hospital, they report on many children. Do we suggest still using the 12 mils and 200% for now to define reversibility? That's a tough one. So again, the variability goes up in younger people. So 10% of the reference value becomes less specific. And using a 12% of baseline is even less specific. And 200 mils might not be achievable if the person is small. So 10% of the reference value, I think it needs to be validated still. It hasn't been validated in children, so you can't use it. So you can still use that 12% and 200 mil number for now, but I wouldn't define it as a strict cutoff. If somebody's close, then they should be investigated further. And the specificity of that change is going to be very high. It's over 85%, if I recall. The sensitivity for asthma is going to be less than around 15%. So the same recommendations are going to come forward where if they don't meet that change, you're going to say it's reproducible, it was normal, do a methacholine challenge. Dr. Lee mentioned bronchodilator challenge that take out without FVC, making it only dependent on FEV1 change may also miss clinically important improvement. Yes. And do we have race-specific equations in our lab? Yes, we do. That is an entirely separate discussion, fortunately for me, and Dr. Sanja Stanojevic, who was the lead author of these recent guidelines and was one of the authors of GLI, is going to be speaking to us about this 2 weeks from now. So I'm going to leave the race discussion with her. We absolutely have these equations. And the numbers are going to be off by 10% or more if you're using the Caucasian or even the all race equations, which is basically Caucasian reference equations. So we have them, and it probably matters it might matter for individual patients, but there are some issues. So Dr. Duong said this has been compared to Z-scores and it's superior, but I'm not sure what she's referring to because I missed when she put that comment in. Andre said in patients with lung restriction, either extra or intraparenchymal, they may never be able to reach their reference value, let alone a 10% improvement. Could this mask concomitant asthma? Absolutely. Any cause of the FEV1 being reduced using 10% of the reference value as being a significant change may miss important clinically important changes, whether it's obstructive disease or restrictive disease. Making this change to the 10% of the reference equation that was derived from healthy people might not be appropriate for people with disease. I'm not ready to make this change, but I think it should inform our interpretation at a more expert level. I think family doctors doing office spirometry absolutely should not implement any of this. And I think in our own practice, we're there needs to be additional validation before we make this change. So it can inform our impression when we have these borderline cases, but I wouldn't advocate that we make the change right now. And then Dr. Duong, should we be doing bronchodilator response at all? I think doing bronchodilator response provides I hope you can still hear me. My audio just cut out. I apologize for my microphone cutting out. Should we be doing bronchodilator response at all? Absolutely. I think we should. I think that there's value in doing it. If somebody has airflow obstruction when they come in the door and they're an uncharacterized patient and there's no contraindications for them to get a bronchodilator and they consent to it, I think that they should get a bronchodilator. I think taking out the recommendations of 4 puffs of salbutamol, I don't know why they took out the recommendations for what dose to give. But I think it's valuable because if that person has a significant bronchodilator response and their spirometry becomes normal, you have avoided a full PFT that might have been required otherwise. And it's specific when it's for the diagnosis of asthma in that situation. And when you're trying to diagnose COPD, you want to see that the obstruction does not go away with bronchodilator. So I think there's still value in doing it. I don't think somebody with a normal PFT where bronchodilator response has not been requested, I don't think it should be done in that person. Now, there are a couple of people with raised hands. I don't know if Victoria is able to unmute them. I think Imran and Mylan are both ready to go.
Hi, Marcel. I hope you can hear me.
Imran, you want to go first?
Sure, thanks. So a couple of points. First of all, I think you did a wonderful job at summarizing all of the studies and highlighting that we still don't know so much.
Mylan, do you have additional comments?
Hello, can you hear me, Marcel?
I'm so sorry. Who are you talking to? Are you talking to me or to Imran?
Hello, Marcel, can you hear me?
I can hear you, Imran, but I can't hear Marcel.
Yeah, I can't hear Marcel, but
and I'm not sure whether the audience can hear both of us.
Audio problems. I apologize.
I can hear both Imran and Mylan, but I don't think Dr. Tunks can.
Sorry, I wasn't able to hear you. I'm back.
Okay, so Marcel, I'll keep it short. We only have 2 minutes. So thank you so much for doing wonderful rounds and highlighting, how much we still don't know, and some of these things are not validated. I had a quick look at the ATS and ERS about 6 months ago, and the ATS seemed to kind of pushing towards not just using a dichotomous less than 10% or more than 10%, but they're kind of saying that this is a continuous range. So when you're reporting to say there was mild, 0 to 10 or 0 to 9 they used, and then 9 to 16, minimal, mild, 9 to 16, and then marked 19 to 26% improvement in the FEV1. So they seem to, and the cohort that they used was the COPD gene cohort. So it's not quite, complete normals, whereas the ERS used BOLD study, the Galen study, and the European Community Health Respiratory Survey, and they are going for the 10% FEV1 as their dichotomous thing. The other thing was, I'm not sure if you mentioned, I might have missed it, was this idea of closing the loop. So after doing the forced maneuver, to take another breath in to make sure that it was within the 5% of the initial TLC, to make sure that they took a good breath in, and more studies are actually asking for closing the loop and making sure it's within 5%. I just wanted to see what you think of that.
Yeah, that's we try to do that, and especially if you're using a turbine type of spirometer, you'll often underestimate the vital capacity on just the expiratory maneuver, and your inspiratory maneuver will be better. And in that situation, maybe the FEV1 to the IVC is better, but that's again, they want you to use the FVC. And it might also pick up cases where they didn't inhale all the way to TLC in the first place. Yeah. So it can be a technical problem, or it can be a technique problem. So we try to do that. The approach that's used in some places in the Middle East, where a spirometry maneuver starts at FRC, they blow out to RV,
then they do a full IC maneuver, then they do a full FBC maneuver, they're more likely to have problems with expiratory flow at the end, but their IVC maneuvers are way better than ours, and their inspiratory maneuvers are better. They're probably more likely to pick up upper airway obstruction, that sort of thing. So it's not universal that we do things across the globe the way the ATS recommends, but in our center, we try to do that full IVC at the end, where the tech thinks the patient can do it. Obviously, in people with airflow obstruction, it's almost never possible. All right, Dr. Duong, do you have any additional comments that I might have missed while my speakers weren't working?
No, not at all. I mean, I was just going to make a comment in the most recent interpretive guidelines. A lot of these guidelines were actually based on statistical and large epidemiology findings principles, and doesn't really apply to disease-specific populations, as you've already mentioned in your presentation. And this is where I think the dilemma arises, because what they're proposing to discard and accept is really based on large populations rather than disease-specific groups, which we deal with when we're ordering these tests. So I think going forward, I wonder whether we should all sort of come up with a working group that addresses some of these new recommendations before sort of going ahead and adopting the new recommendations, just to give it a little bit more thought. I mean, just so that, you know, it applies to our own population and our practice. So that's just my thought, because there's just a lot of stuff that they're proposing that are quite radically different from the way we've been practicing right up to this point.
Yeah, I agree 100%. And that's why I frame this as the beginnings of a discussion for the Respiorlogy group as a province. I think that the previous reference values, the previous methods of using fixed cutoffs obviously have major problems. But these new guidelines are incomplete as they're not a clinical practice guideline. Yeah. It's a technical standard for how do we move forward in researching this problem, what needs to be validated and what has been validated already. So to me, this seems like a work in progress, but not something for immediate implementation. I agree 100%.
Okay, thank you.
All right, I apologize for the technical difficulties, and I apologize that we're out of time, but I do encourage everyone to return 2 weeks from now. We're going to have Sanja Stojanovic talking to us about racial adjustment and GLI in a more general sense. And then, of course, next week we have a double header from a presenter on asthma. I'm hoping to have all of these rounds posted on YouTube going forward for any speakers who consent. Hopefully this one will be up within the next week or so. So I want to thank everyone for joining us today.